You plan for everything, but nobody planned for this. When a stroke enters your life, the medical team knows exactly what to do. The doctors, the nurses, the therapists, they handle the crisis, and then one day they send your loved one home. And suddenly, you're the caregiver. No training, no manual. What we discuss on this show is what I wish someone had handed me on discharge day. Real information, honest conversation with someone who knows exactly what you're going through. Because I've been there too. So let's begin the conversation. I'm very excited about our guest this morning. Dr. Black is going to be joining us and talking about behavioral and personality change. Now, he is quite the expert, and so I'm going to read his information because it's a lot. So, Dr. Black is a board-certified neuropsychologist and the founder of Idaho Neuropsychology. He's a native to Idaho. He trained at Michigan State University. That's where my husband went, and completed his fellowship at Allegheny General Hospital in Pittsburgh. It's a level 1 trauma center, where he later joined the faculty. After returning to Idaho in 2018, he served as lead neuropsychologist at St. Luke's Health System, working with patients recovering from stroke, traumatic brain injury, and other neurological conditions. Today, through his Boise-based practice, Idaho Neuropsychology, he specializes in neuropsychology evaluation, including support for stroke survivors and their caregivers. Whew, I thought being a caregiver was a lot of work.
It is a lot of work, and it's harder than my job, that's for sure.
So, Dr. Black, just to let you know, my background was nursing, and I had been a nurse for over 40 years and actually worked in a neurosurgical unit.
Mhm.
And then my husband had a stroke, and with that came this new role. And
Mhm.
you're just not prepared for it. And so, as a care partner, and so many care partners that I've talked to over the years, we've experienced firsthand these cognitive, behavior,
Mhm.
personality changes. Please share a little bit about your work and what families often misunderstand about their loved one.
Well, thank you first and foremost for having me. As I was sharing with you before the show, this is such a important passion topic of mine, and I think no one is prepared for what happens after a stroke. It doesn't matter if you're a stroke expert. It's one thing to be on that side of the bed, but it's a whole nother to, of course, live with it day in and day out. And I think one of the most common things that come out after anyone has a stroke is that first and foremost, there's just a profound shock to the system. And when I say system, I don't just mean the person who's experienced the stroke, but of course, it is like a ripple effect when you throw a stone in a pond. It affects every single person in that individual's life. And there's just shock that comes with that. And then, of course, all the grieving that comes with the profound changes that can happen. And the other piece of all of this that, again, I don't think we talk enough about is that, of course, this is such a dynamic process, meaning there's change almost every day. Now, some of those changes are positive as recovery unfolds, but other changes are very difficult and challenging, but no 2 days are the same. And that makes this a very unstable or destabilizing process for both the person who has survived the stroke, but also their loved ones.
Dr. Black, you hit the head on the nail. I tell you, I still believe that. You know, the crisis or the stroke itself happens in a second,
Mhm.
but the recovery, it's a marathon. It's
Mhm.
unbelievably
A
marathon.
never-ending marathon, by
And
the
never
way.
and yes,
Yeah.
exactly. And
Mhm.
so in my case, my husband, medically, is recovering well, but he's dealing with all the cognitive and
Mhm.
7% things. And
Mhm.
one of the things, I find, and a lot of my caregivers find is that we're emotionally exhausted because it's the
Mhm.
up and down, and you just don't know what you're going to deal with from day to day. Um,
Absolutely.
so why is that?
Mhm.
What do you think is the cause of that? Or,
Mhm.
I because there's some days when you're not doing physically work, but you're
Mhm.
exhausted.
Yeah, I mean, I think there's a number of different things that can happen, and I'll just touch upon maybe some of the most common. But part of what you're describing is what I think of as a continuum of caregiver resilience on the one hand, where caregivers or care partners feel like they have the energy, they feel sufficiently engaged, they're optimistic. And then the next level is what we call caregiver distress. And frankly, virtually every caregiver experiences this one. And that's where our emotional and energy gas tank starts to dip into that yellow zone. And with that caregiver distress, there's often feelings of being maybe a little more irritable. We're not sleeping as well. We're ruminating, thinking about all the things that we have to deal with. The weight that we're carrying on our shoulders gets heavier, and we still have positive moments, and we still have moments of joy and pushing through, but it's more difficult and it's more mixed. And then, of course, the most dangerous uh, thing that can happen to any care partner is what we call caregiver burnout. And that's the red zone on the caregiver energy gas tank. And that's where often caregivers themselves are experiencing more profound depression, might be experiencing thoughts of hopelessness or helplessness about the situation, finding themselves frequently tearful or extremely irritable, resenting the situation. And so, to your point, that emotional exhaustion is extremely common. In fact, I would argue, I don't have stats on this, but in my experience, 98+% of people experience that emotional exhaustion. But we're thinking about in terms of degrees. How significant is that? And are we in distress, which is pretty common, but we have to monitor it, or are we approaching burnout, which is an absolute crisis for that care partner? Now, to answer your question, why does this happen? My experience has been that part of it is because when let's say you're in a long term marriage, as I presume you were at the time your husband had his stroke. We get into these grooves where things are almost automatic. And by the way, that could be positive or negative. But when we're in these grooves and things are automatic and they're almost effortless, and we have these routines that we follow not only in our own lives, but with our loved ones, there's communication routines, there's daily routines. It's less effortful. What happens after the stroke, and as we were talking earlier, when there's just nothing but change, right? Every day brings change, whether it's positive or negative. That change itself and adapting to the change, trying to anticipate it, is exhausting because it creates unpredictability and uncertainty, and that's just tiring. And so I think that emotional exhaustion is normal. I think it's part of almost every care partner's journey, but it takes a toll, of course.
Boy, it sure does. When the crisis happens, when the stroke happens, you are so surrounded
Mhm.
by so many healthcare professionals, friends, family are there
Mhm.
to support you. But then, for us, we're 5 years out. And it's not like
Mhm.
having a broken arm where you see a
Mhm.
cast and people are like, oh, you poor thing, you broke your arm. You don't see that, you
Right.
know? And so a lot of times, I think from a care partner perspective, they look fine. So you should be fine
Mhm.
too, you
Mhm.
know?
Absolutely.
Yeah.
Yeah. Yeah, and that can lead to misunderstandings, of course, even with well-intentioned people, right? All good intent, friends and family can look at someone and think, well, they look fine, and yet not understand. And then the other piece that comes up again in almost every care partner story is that there's a disconnect between what the care partner sees living with their loved one, maybe 24/7 if they're still at home. They see all the ups and downs, all the dynamic change, the times when their loved one is on, and then the times when maybe they're off, right? And everyone else is only interacting with them in slices of time. And of course, medical professionals, we interact with people the least, right? Often, if it's a PCP, a primary care provider, you might have 7 to 15 minutes with that provider if you're lucky, a couple times a year. And so it's a little slice of time. And so the further out we are on that periphery, the less likely we are to see this incredible dynamic process unfolding. And of course, that contributes to the care partner's exhaustion as well. There's a sense of you just don't get it.
You know what? Every time I visit a caregiver and families, that's the one thing I hear from them. Oh, finally
Hmm.
someone that gets it.
Hmm.
It's just so
Hmm.
crazy. And I
Hmm.
think, for for myself, people will come up and say, oh, everything looks great. He's 5 years out. And my
Hmm.
first thought is, you live with him 24/7.
How dare you?
Yeah. Now,
Yeah.
now, Dr. Black, I don't say that, but I tell you, it's going in my mind.
I'm sure it is. And one thing that I work with families on trying to understand is that for the most part, when friends or family make comments like that, or colleagues at work, my experience is it's usually with positive intent, right? They're trying to be reassuring, but the irony is it can feel deeply invalidating. And that's the piece that I don't think people understand, is that when we dismiss the changes that are there, or the barriers or challenges that are real, because we're trying to focus on the positive and be optimistic, on the one hand, that's really lovely, but on the other hand, it can feel deeply invalidating to the tremendous loss and grief that's still going on.
You were so correct on that. Rick's been out several years now,
Mhm.
and I find myself wondering, could he, can he do more? Or,
Mhm.
is he just playing the stroke card? Like, oh, I can't do that. I had a stroke.
Now,
Um,
part of this is called marriage, just so we're on the same page, right? So, what's stroke? What's marriage? But go ahead. Yeah.
yeah, exactly. Exactly.
So,
So, how can we as
mhm.
caregivers distinguish
Mhm.
between, what is they just don't want to do it, like any
Mhm.
normal person,
Mhm. Mhm.
and their neurological fatigue and, their
Mhm.
apathy. My husband, unfortunately, got the apathy card.
Mhm.
So
Mhm.
it's been a challenge. And some days I
Mhm.
get really frustrated. So how do we know the
Mhm.
difference? Or, when should we say, get off your keister and go do this?
Oh, I love this question so much. And this is really one of the central challenges after a stroke. And if we can unpack this just a little bit, because it's a bit of I think a detailed, and the details are really important, topic. So let's first define what apathy is, for those who may not be familiar. I think we all use this colloquially in our language, but at least in psychology and in medicine, there's a specific definition. And so apathy is considered a disorder of motivation, meaning someone who is apathetic will often tell you what's important to do. They may even know how to do it, and they have all the capabilities to do the activity, but they cannot get started. So, the analogy I use with families is, imagine an engine of a car. You have all the parts, you have gas in the gas tank, and yet you take the spark plug out. That engine will never turn over. That car will not drive, even though you have all the parts. And it's because you're missing that spark to get the engine cranking. And that is apathy. And so, apathy, of course, is very common after stroke. And in fact, depending on the research studies we look at and the type of stroke, there's a lot of factors. It's actually probably the second most common behavioral and personality related change after a stroke. And it's around 30 to 40% of stroke survivors have apathy. I mean, that's a huge percentage. And apathy, and no one talks about it. And no one assesses it, by the way, in standard post stroke medicine, right? Even though we have scales to assess this, it's literally just an invisible topic. And yet, we know from not only research, but our own lived experiences, that apathy is one of the most powerful predictors of post stroke recovery. Because if someone is apathetic and they're having difficulty initiating activity, they're not going to be as engaged in social activity. They're not going to initiate hobbies, and they're going to have a hard time participating in rehab, at least independently, meaning they're going to get up, lace up their shoes, get out the door, go to rehab, then come home, maybe grab lunch, and then go get a coffee with a friend. All things we know would help recovery. They can't initiate those different parts. And so, apathy, to your point, is not only not discussed, it's underassessed, and yet it's one of the most powerful predictors of post stroke recovery. And given that this is a Care Partners podcast, it's one of the features that drives Care Partners bonkers, because there's a real feeling of, well, is my loved one just lazy? Do they not care? Have they given up? Do they not want to get better? These are all questions I hear on a routine basis. And it's a presumption. And this is why I'm glad we're talking about it. It's a presumption that their behavior and their motivation is in their control. And here's the key part with apathy, it is not always psychological. It's not just something to get over or to push through, it is neurological. It's part of the brain change after a stroke. And so, again, it's literally taking out the spark plug of the car. And so we have to approach it from a very different standpoint because the person themselves will never be able to turn that engine without significant supports around them.
Dr. Black, I just have to ask, do you live in my house? Do you
I take it as resonating.
Yes, absolutely,
Mhm,
and I think it's gonna resonate with a lot of our listeners
mhm,
because it is something, and, when
mhm,
I was at the hospital and, you're they're getting your discharge and they talk about, taking your medicine and all the
mhm.
practical things, no one
Right.
ever talks about this, and it really
Mhm,
is a big black cloud over your head.
mhm,
And it's been
mhm.
challenge for myself, and I know a lot of different caregivers. And it's really wonderful to hear someone say, "Okay, they're not just being lazy. This is something
Mhm,
that they
mhm.
can't control," because it you are working so hard as a care partner to keep
Yes.
them healthy and help them get better. And when they're not
Mhm.
motivated, you just get frustrated. Absolutely.
Absolutely. But we have to change the script about what we're observing, right? And so I am a big believer as a neuropsychologist that the story we tell ourselves about what's unfolding has a tremendous impact on how we perceive it and how we either thrive or we experience distress. And apathy is a really powerful example of that. If the narrative in our mind is, well, my loved one just doesn't care or they're not trying hard enough, all of a sudden, one, that pits us against them, but two, it really spoils kind of the environment for that loved one to have maximum success. And by the way, these are very normal reactions. There's no judgment here. It's normal to question why can't my loved one who used to be very successful, independent, high achieving, and now it's kind of I call it bump on the log syndrome. And now they're just sitting in the lazy boy chair and they could sit there all day if I let them, right? It's this total disconnect of this is not who I married. But if instead the narrative is this is part of the stroke, this is part of the brain damage that occurred, well, all of a sudden now we can open our hearts to maybe more compassion about bump on the log, right? And approach that from a very different emotional space, which allows us to join with our loved one rather than be against them. So, as someone once described it to me, let's sit on the same side of the table rather than it across the table from each other. We're on the same team fighting this together. We're not gonna fight each other, right? And apathy is just one more thing that we have to overcome together as a team.
This is just amazing for me because I've been that person that's been on the other side of the log,
Uh-huh.
even though you understand it, it still is hard to
Of course.
live with it. So what are some tips or what are some things you can tell caregivers to kinda help us get in the same place as, the bump on the log? I mean, do
Mhm.
we buy another lazy boy and sit next to them? I mean, what should we do?
Lazy boy stock is gonna go up after this,
Yeah.
yeah, yeah. What a great question. Um I think this is going to be highly unique for each situation. Okay. And of course, let's just acknowledge that. And let's just say we're talking about spouses, because that is the most common care partner is a spouse. The next most common, of course, is an adult child. Let's just talk about spouses for a second. They had a full relationship and full marriage before the stroke. And those, of course, are highly variable in terms of how much joy and satisfaction and connection there was. And that has a huge impact on how couples survive after a stroke, right? So I think it really depends. But in general, some principles are, I think, recognizing when it's okay for our loved one to maybe be more passive and to have less activity and to honor that capacity because they have reduced capacity to do things. So we're going to honor that. And the second part of this is to recognize that because they don't have that spark plug, if the loved one is going to do something, and I'm talking in kind of black and white terms, this is all shades of gray. You can have small amounts of apathy, medium, and large. But for all intents and purposes, the care partner in many ways is the spark plug. And you've probably lived this, right? If there's something really important that has to be done, I'm going to have to literally make it happen for both of us, right? Um, and so I'm going to choose my battles really carefully. And I call it the vital few. What I mean by that is, what are the vital few things worth fighting for, knowing it's going to take a large amount of energy? It's going to be emotionally exhausting. It's an investment, right? Now, vital few might be we are going to therapy, right? Physical therapy, occupational therapy, speech therapy, that is non negotiable. Even though it may be a fight to get out the door every day, we're going to therapy. Another vital few I always recommend is we are going to maintain meaningful contact with select loved ones. Now, our social group may be smaller now than it was before because we can't maintain all of it, but there are certain relationships that are worth fighting for, and we're going to fight for those. That's in my vital few. There may be a spiritual side to that, so we get out of the lazy boy and we're going to either church or some type of community gathering that spiritually nourishes us. And so to your question, I think it really depends on the couple. I think we have to recognize they're not going to do everything they did before. We are not going to do everything as a couple we did before, but we are going to get alignment and clarity on what are the vital few we're going to fight for. And that's something I do when I'm doing, for instance, caregiver coaching is help the families identify together what are your vital few and then get agreement from both of them. And I tell them, listen, this is going to be really uncomfortable because you may not have the motivation or energy to do it, but you're agreeing that these things will be done. And so we're going to treat it like a job. We don't get to not show up to work just because we don't feel like it that day. We'd get fired, right? And we're going to agree to these things and then make them happen. But does that resonate at all with your experience with Rick in terms of your vital few?
Absolutely. And what I found too is when I wrote my book, Stroke and the Spouse, and we were dealing with apathy in the
Mm-hmm.
book, you know, I had to learn some workarounds.
Mm-hmm.
I can say in the morning, hey, I need you to do, I
Mm-hmm.
don't know, X.
Sure.
Well, by afternoon, it may be gone. And so
Mm-hmm.
it's kind of, we now have a calendar on our thing
Mm-hmm.
of the kind of
Mm-hmm.
things. I'm learning that what things I ask to get help with or for him to do, they don't have to be immediate. And I
Oh,
think
I
that
love
is,
that. Yes.
I think that's been a key to help
Yes.
us is
I
that,
love that.
if he gets it done today or if he
Mm-hmm.
gets it done in a
Mm-hmm.
week, it's
Mm-hmm.
okay.
Mm-hmm.
So I think I kept wanting to pull him back to the person he was
Of
pre-stroke
course. Of
and
course.
not honoring the post-stroke. And I think
Mm-hmm.
many caregivers
Mm-hmm.
feel that way. I think the other thing too, Dr. Brock, I was curious about is as a care partner, we're now taking on that other person's role. And
Yes.
I I'll be honest, I really had no clue all the things he brought to the relationship
Sure.
because we've been in it for so long. It's
Right.
just,
Right.
I'm the
Well,
one.
and of course, each partner in the relationship usually overestimates how much they're doing in the relationship,
Yes.
right? That's just again called marriage. I'm pretty sure it's Latin for overestimating what we bring to the table. But yeah, absolutely. And yet you quickly learned, oh my goodness, he probably did a lot more than I maybe appreciated. But now I have to do that too.
Oh,
Yeah.
absolutely. And it's
Mm-hmm.
funny when I'm out with friends or whatever, and
Mm-hmm.
we all complain about our spouses, you know that.
Sure.
And it's like, oh, he didn't put the dishes in the dishwasher. And I think,
Mm-hmm.
oh, I would love to have that worry.
That would
you
be the
know,
old Rick, maybe. Yeah.
yeah, yeah, exactly. Um, you know
Mhm.
what? I just can't tell you how wonderful this has been to listen to you and to hear that what I'm experiencing and what other care partners are
Uh-huh.
experiencing is not abnormal. Or,
Mhm. Mhm.
we always hear the term, oh, you're so strong. Well, we're not so strong. We're just trying to
Mhm. Mhm.
navigate this new life. And what
Mhm.
you've brought to the table um, is is going to really help us navigate. What are some final thoughts? We've got some time, but what are some final thoughts or things that you feel like, boy, I really want caregivers to know or care partners to know?
Mhm.
What are the things that you want us to leave this podcast going, hmm, I'm going to do that.
One of the most common experiences is that, and by the way, this is all of this is normal. It's just it's abnormally normal, meaning strokes are abnormal. It's not something anyone can prepare for. But the experiences we're talking about are so normal after the stroke, right? The world gets turned upside down like a snow globe. I have a good friend, she's a nurse practitioner, and she describes our lives as snow globes. And this is one where that snow globe just got shook really hard. And it's going to take a long time for things to settle, right? One of the things that comes up in every case is that, especially in the immediate aftermath of a stroke, and I'm gonna classify that roughly as the first 3 to 6 months. And again, it depends on the person. We're just in survival mode, right? But when we move out of survival mode, um, one thing that often happens is that care partners, by necessity, become so consumed and fixated on their loved one, making sure all their medical needs are being taken care of, all their daily needs are being taken care of. They're just trying to survive, especially if they're still working, um, all the things, right? What happens is that care partner, as a human being, as an individual, begins to disappear or is diminished. And one of the things I really want people to do is to fight against that and to start to take care of their own needs. And we think of that very broadly, and that can be physical needs, emotional, of course, financial, spiritual, all the parts, right? And so this is really where respite comes into play. And respite, broadly defined, is getting in some outside help to allow the care partner to have a break, a temporary break. And you asked, what is something that I wish people knew or could take away? It's that most care partners need respite, and yet so few take it or even think to seek it out. Now, do you mind if I share with you a couple rules about respite that I try to teach? Okay. Respite, I think, is such a powerful tool, and yet it's often misused. So, what will sometimes happen is a care partner will finally get respite. And by the way, respite could be informal, such as one of the children, the adult children, come over and spend the day with dad, right? And so mom can go out and do things, right? Great. That's perfect. It's beautiful. That's respite. But what happens is the care partner usually uses respite to try to tackle the horrifically long list of to do things that has only been getting longer. And so they're faced with this overwhelming list of neglected tasks and all the things. And usually they break down in tears because they realize I have 4 hours and yet I have 390 days worth of tasks, right? What I tell people is that's the wrong approach. Now, to be fair, we have to reserve some of the respite time to get some of those things done. That's just life, right? But a more powerful use of respite goes back to what we talked about earlier, that caregiver gas tank, resilience versus distress versus burnout. I think about this in terms of energy exchange. Caregiving reduces energy. What we have to do during respite is find the activities that will start to restore our energy, fill our cups back up. And so that might mean going out to lunch with a dear friend that you haven't seen since the stroke, or maybe you've talked with a few times on the phone, but to go and have a nice long lunch. Go grab a cup of coffee or tea. It might mean going and taking a walk in nature or getting a massage. Whatever it is, we want to do something that restores us because that helps us stay in the fight longer. And so this is something I wish more people understood, is that once you get through that initial shock, we have to start to create intentional time to restore the care partner. And the most effective way to do that is through respite, but at least 50% of the respite time needs to be built around activities that will fill the cup and increase energy and rejuvenate and revitalize. And if people do that, what I experience over and over again is they start to get out of distress and towards resilience. And all of a sudden, they feel like they have more wind in their sail to be in the fight longer. And so that's one of the most powerful takeaways I think I can share.
I just want to thank you so much for, first off, filling my cup this morning and helping me to understand some of the issues that we all are dealing with, but just for the work that you're doing for caregivers and care partners and the stroke survivors themselves. I am excited. I would like to have you on again some other time. I
I would
think you
love
have,
to come back.
yeah, I think it was a great, great conversation. So again, thank you so much for your time. It was a wonderful discussion, and I just feel a lot better this morning. And I hope
Well,
I hope our caregivers feel the same way.
I hope so too. And I just want to say thank you for everything that you're doing out there. The care partners are often the most neglected person in this whole equation, and yet they're the captains of the ship, keeping everything moving. And so, thank you for your mission and your focus on this. It's a really powerful topic.
Well, thank you again. So this concludes this episode of Both Sides of the Bed. And again, thank you, Dr. Black. It's been a pleasure. Every episode, my goal is simple, that you leave knowing we're in this together. Caregivers don't have to figure things out on their own. My hope is to share the education that you will need and to provide resources of value. If today's conversation helped you, share it with someone who needs it, a family member, a nurse, a friend who's going through this right now. That's how we find each other. I'm Lana. Thank you for being here. I'll see you in the next conversation. Make sure to stay connected on social media at Care Power Connect and on my website, carepowerconnect.com.